much, Vicky. And I thought this was a good subject to choose maybe to kick off these webinars, because we've obviously, despite the really changing circumstances with the coronavirus, we've obviously got lots of people out there that are still suffering from skin disease, and one of the most common is acne. So acne it's a very common disease. It's pretty much a near universal skin disease that affects, as this slide shows, at least 85% of adolescents worldwide. However, we are seeing that certainly dermatologists and skin specialists are seeing later onset acne, a lot of acne occurring in later life, particularly in women. And acne at any age, unless it's promptly treated, can certainly leave permanent scarring. So the severity of acne can be anywhere between mild to more severe, but in fact, even mild acne, it's certainly not mild to the sufferer. And often you'll get teenagers coming in, particularly when they have early onset acne, that are incredibly embarrassed and emotionally disfigured, as well as potentially disfigured by potential scarring. So mild acne needs to be taken seriously, and it is something that we can treat very readily now. And then the more severe forms of acne, we've got lots of different treatments that can be used, as I'll go through. And one of the main reasons for prompt treatment is to not only clear the active disease, but to reduce scarring and later disfigurement. And particularly, there's important with acne, and a lot of inflamed skin diseases affects different phototypes differently. The darker, olive-skinned, skin of color, all respond differently to inflammation. And as this young lady showed, you not only get erythematous scars, but you get hyperpigmented scars and marks. And these can last for a considerable time, can even be actually permanent. So what about the changing of acne, changing presentations? Well, we're still seeing the main presentation in the teenage years, and certainly some of the earlier studies, of which Bill Cunliffe in Leeds was one of the pioneers in the UK, very clearly demonstrated that acne was most prevalent in teenage and also in male patients more than females. But what we're seeing, I think now, and many of us are, I've certainly see this in our clinic, is that even though acne is most common in teenagers, we're seeing more frequent acne occurring in women, in adult women, and in men. Late onset acne, particularly in women over the age of 20, is increasing, and it's more likely to persist as well. In males, it's less common in adult life, but it certainly does occasionally occur, particularly in men who have had more severe acne when they were younger. So, but in particular women, we're seeing this greater onset and recurrence in the later age. And it tends to differ in the adult woman from those in the adolescents. There's more papules, pustules, there's fewer comedones. It's more often on the lower face. And this lady, this younger lady in her late 20s particularly illustrates that. You've got much more common inflammatory papular acne on the lower face, particularly the perioral area. What about the causes of acne? Well, obviously the predominant cause is androgenic hormones that can be increased and released in stress premenstrually, with some acne, some medical products, some cream products, medicines, contraceptives, and also during and after pregnancy. And these act upon the skin in a variety of different ways, but particularly targeting the pilosebaceous gland. And what happens is that the androgenic hormones stimulate sebaceous gland activity. And one of the earliest clinical signs of acne is that of seborrhea, and that's something that the patients, the younger patients, will often say, and indeed the adult women acne will often say that they notice an oiliness of the skin, often of the forehead, the cheeks, the nose, and also the hair. And then the next event, it is thought, this is the sequence, that you then get a blockage of the pilosebaceous duct that then leads to blackheads and whiteheads. Now, even at this stage in the early acne, when you've not got that much inflammation, these blackheads and whiteheads actually can be quite disfiguring, and as this slide shows. Interestingly, there's also been work that the other thing is the inflammation of acne, and it's now known that the inflammation of acne obviously is one of the primary signs of more progressive severe acne, but also when they've got the comedogenic form, the blackheads and whiteheads, there is an element of inflammation that's already occurring there. And the inflammation is due to colonization of the different acne bacteria, now known as Corynebacterium acnes. It used to be Propionibacterium acnes, and this is an acne bacteria that's actually numerous species that builds up behind the blocked pilosebaceous duct. As I said, that even early acne, and if you can look at this slide which we've taken with a filtered photography, even in areas that don't show on the regular photograph particularly as inflamed, you can see scattered inflammation even amongst the clinically non-inflamed areas like comedone. So inflammation is an early event in acne. And the acne bacteria, the nomenclature is becoming more complex. There are now known to be numerous subsets of P. acnes or C. acnes phylotypes, some of which are increased in inflammatory skin, some of which are increased in comedones, and so supposedly non-inflammatory acne. So there's been a suggestion that that different acne bacteria phylotypes can have different clinical effects on the skin. And interestingly, some populations don't seem to have any acne. And this led to quite a lot of research done in two groups, the Kitavan Islanders in New Guinea and a tribe in Paraguay. And this, the conclusions of some of those studies suggested that it was due to a non-Western type diet, no dairy, low glycemic index, and that might have been one of the other reasons. The other reason clearly is a possible genetic link as well as the dietary. But certainly dietary stimuli for acne has been well documented, and there's been numerous studies that have shown quite clearly that dairy products and high glycemic diets can indeed affect and induce acne in certainly susceptible people and make acne worse in susceptible people. So there's numerous other causes of acne. Comedogenesis can occur as an early event from various creams, particularly some of the creams containing heavier vehicles. Oils can be particularly comedogenic. Some sunscreens, I will often see patients that will quite clearly say that they have had onset or worsening acne when they've started to use different sunscreens. Pomades, particularly those used, some of the oily hair straightening pomades that some patients will use can give acne on the foreheads. Some of the facials can actually, ironically, produce acne by producing increased outer skin cell turnover and pilosebaceous duct blockage. And even in the recovery of some treatments such as lasers, pulse lights and peels in the susceptible patients, in the clinic, they can also induce temporary worsening of acne. So all these things for the clinic, the practitioners, are worth noting. And in the susceptible patient, we will often and will frequently use anti-acne treatments before we start them on those treatments to try and prevent that worsening. So what's the key? Well, I always say you've got to take a really good history before you examine the patient. And certainly with acne, that's absolutely the case. So family history, does the woman particularly have any signs of polycystic ovarian syndrome or androgen excess? Do they have hirsutes? Do they have oily skin? Do they have irregular menses? Are they getting any diffuse scalp hair thinning? So all of those things are important to look at. Are they stressed? What sort of diets do they have? What's the age of onset? Contraception oral contraceptives can actually precipitate acne, both when you start them and when they stop them. Pregnancy, post-pregnancy, IVF, all changing patterns of hormones that can stimulate acne. Many women in the perimenopausal, postmenopausal stage are now taking androgen supplements, and that can definitely create acne in the older patients. Then ask them about comedogenic creams and cosmetics, and also acnegenic medications. Some of the antidepressants, the classic example being lithium, some of the barbiturates can all produce acne. So all of those are important things to ask. And this is a relatively mild acne or moderate acne in a female teenager, but if you look closely, you can see that she's definitely got increased hair growth on the lateral face. She may have polycystic ovarian syndrome with androgen excess. And sometimes you don't need the complete syndrome. You can have androgen excess that can then stimulate the hair and the acne. But you can also have what we now realize is that we call it androgen sensitivity. You may have normal androgen levels, but the pilosebaceous glands and the hair follicles react more, and they produce acne as a probable increased sensitivity to those androgenic normal levels, but androgenic stimuli. So the acne history helps to guide our treatment decisions. And how long have they had acne, how severe it has been, what triggers, what past treatments. Now, it's clearly important to know what past treatments they've had to decide on what you're going to advise. And that's particularly true. You don't want to repeat some of the treatments that they've had side effects to, or that have not been particularly successful. So all those sort of things are very important. And I always go through these clearly, carefully. What skin products have they been using? What skin treatments have they had? Some of those skin treatments actually can create problems. Retinoids and some of the other topicals can create dryness, and they'll have often stopped using the treatments because of that irritancy and dryness. So a very careful history is important. Now, topical treatments in this mild to early stage acne is usually successful, and that is what I will often select in this type of patient. And we've got a variety of different topical treatments that we can use. What about this type of acne? Well, this type of acne patient would be on the cusp of either going to oral and topical or just topical. And some patients don't want to go into straight away into oral therapy. So start them off on some of the topicals, get there, making sure they're compliant. One of the big problems with acne topicals is that they can not feel quite, they don't like the feel of them. They don't like the fact that some of them are very drying. So you've got to encourage them. And we've had a specialized acne clinic for some years at our clinic, and we will stress with our staff, they will follow up the patients as well, and they encourage them to stay with a course of treatment. Most treatments for acne don't start kicking in, don't start working for several weeks, sometimes 2 to 3 months, and a lot of encouragement and hand-holding at that time is important to encourage them to continue. What about the different non-prescriptions that patients can actually obtain? And there's numerous ones in the pharmacist and that you can buy, including sulfur-containing preparations, salicylic acids, benzoyl peroxides, and retinols. And these can be very successful in some patients. In quite a few patients, they do create problems with dryness, sensitivity, and scaling, and that can lead to occasional problems with them losing their enthusiasm to continue with these treatments. And again, if they use some of these products less often, they can get around that dryness and redness, but they're often not giving that guidance to do that. Some of the prescription products, and we have quite a number now, are usually variants of retinoids, and there's one that in the UK that's quite frequently used, and that's adapalene in gels, in lotions, and often in combinations with benzoyl peroxides. And they're very effective often, but they can produce in some patients quite a lot of skin redness, irritancy, scaling, dry skin, etc. Tazarotene is an excellent one, but it's unfortunately not available at the moment in the UK. I'm not sure why. And isotretinoin gel, which used to be available, is also no longer available. And certainly the conventional strengths of tretinoin that we use in photo-damaged skin is often much too drying and red for a lot of acne patients. And I'm not a believer in having to create redness and scaling to get a benefit with retinoids. You don't have to. You can scale back and you get a much better result if you go gently with all of these agents. Do it every second or third night to start with. Let the skin become more tolerant of them, and then you'll get patients much more likely to persevere. Benzoyl peroxides are very effective. Also, again, they have the drawback at times of dryness and irritation. Antibiotic gels and lotions are also very effective, and there's a variety of them ranging from topical clindamycin, erythromycin. One of the things, they do tend to stop working after a time because of antibiotic resistance. The bacteria become resistant to them. Azelaic acid is a useful product, often used. I will use these in combination. It doesn't have the greatest efficacy when used alone, but it can be very useful when used in combination. I'm just disconnecting my phone, sorry. It can be used very effectively in combination. And it's also very useful because it's got very mild skin lightening properties. So in skin of color, that's often a very useful adjunct to use with the other treatments. So I'd often use the tretinoins and the adapalene rather in the evening, and the azelaic acid in the morning. And then after applying the azelaic acid, they would then use their sunscreen and so forth. So we were interested some years ago in trying to produce what we thought was a better topical product that might be effective, that was hopefully effective, importantly easy to use, not irritating, ideally would be antimicrobial, and it would reduce comedogens, etc. And it would also could be used for maintaining clear skin. So all of those we thought I'd apply to my thought tank, and we came up with a series of products that we've had available now for 5 years or more. And the ingredients were selected: a slow-release salicylic acid, which reduces the risk of irritancy. Zinc is also known to be anti-acne, and that can be very effective. That was incorporated. It may reduce some of the seborrhea. The niacinamide is very useful for a number of reasons. It helps to repair the skin barrier with the damaged skin of acne lesions. It helps to reduce some of the seborrhea, and it also, interestingly, is anti-inflammatory. And then the antimicrobial that we chose, which was not an antibiotic, we wanted to avoid antibiotics, was eucalyptus extract, which has been, over the years, had a lot of proof for antimicrobial action. And this was an ideal patient to use that type of product on to reduce the acne. So this was where the products were used alone. And in addition, here we combined it with oral antibiotics with the serum and the wash. And the serum can be used twice daily and can also be used before applying sunscreen in the morning. And then you can also target individual lesions several times a day, including through makeup in women, to actually target the inflammatory pustular early papular lesions. So basically that's what we developed, and the products have a range as is shown here. Moving on now to the treatment of more severe, moderate to severe acne, and there are pros, cons, and side effects of each of these. Basically, the antibiotics are highly effective. They don't often only work as antibiotics. They're also anti-inflammatory, and the side effects are different. For example, doxycycline is effective. I will always advise they take it in the early evening with food, because that can reduce the frequent side effects of heartburn and indigestion pain. So doxycycline effective, sometimes used at a relatively low dose, 40 milligrams a day in the early evening. The same with limocycline or tetralysyl, again used in the early evening with food, highly effective, and I think fewer side effects than doxycycline. These are tetracycline analogues, and therefore they can have a photosensitivity, light sensitivity side effects, which is why I tell them to be used in the early evening to avoid that. Some of the other antibiotics which are less effective but often well tolerated include erythromycin and a variety of others. There's some newer ones I'll talk about that are being developed in the United States that are now available there. Some of the anti-acne oral contraceptives, of which the one most frequently used in the UK is Yasmin. You've got to be aware that that type of oral contraception has a higher risk of some side effects, including thromboembolism, etc. Spironolactone, a highly effective drug used in adult women, and it's used for its anti-androgen, androgen blocking effect on the pilosebaceous gland. I think it's used much more frequently in the USA than it is here in the UK at the moment, but I've used it extensively in a lot of my adult female acne patients over the last 5 to 10 years. The dosage is usually 100 milligrams to 150 milligrams each morning, usually very well tolerated. We have to make sure that the patient is not pregnant. We advise against pregnancy while they're on it. And it can be combined with other treatments. Some of the other hormonal treatments include, I'll come on to that in a moment, flutamide, etc. Again, they have their own side effects and really need to be used by, I think, dermatologists, as does oral isotretinoin, a highly effective drug, but obviously we have to be careful about pregnancy avoidance while on it because it is a potent teratogen. And then at times, low dosages of prednisolone can actually reduce acne by its hormone blocking effect and also its anti-inflammatory effect. So that we do have a wide repertoire as dermatologists to treat these types of patients. Oral isotretinoin, highly effective, and I'm a great believer in starting at very low dosages. You need to be careful with isotretinoin because it can produce a lot of dryness, a lot of skin fragility, and you can get a series of side effects such as muscle aching, muscle pain, some nosebleeds, headache, and so forth. Very important the patient has to be monitored carefully and followed up. So at the moment in this country, it's used under the supervision of dermatologists, but a highly effective treatment. And then, as I say, hormonal treatments are several, and I will often combine these with other treatments such as antibiotics. I'll sometimes have, for example, patients that have been on isotretinoin that have relapsed with previous courses. I'll add in spironolactone to the isotretinoin to get the better chance of long-term clearance and then maintenance. There are other ones that we can use, cyproterone acetates, low-dose corticosteroids I've mentioned, flutamide, pardon me, flutamide is another excellent anti-androgen, but you have to be careful with its use. Blood tests are all important for a variety of different reasons with these drugs. Although I would say that some of the studies on long-term use of spironolactone seems to suggest that we only need to repeat the blood tests every year. We need to repeat the pregnancy tests more frequently. And then there's an interesting new class of anti-androgen that's in development in the United States called clascoterone, and that seems in early stage studies to be effective against acne. If it is found to be effective in longer term studies, this could be a very important new addition to our therapeutic range for anti-acne products. So isotretinoin, highly effective, as this patient of ours has shown. This was about the second or third time she needed treatment, so I added during the last 3 months of her oral isotretinoin treatment spironolactone in the morning to maintain remission. And then, of course, why do we want to treat acne promptly? Because we want to clear the acne itself, which is distressing and embarrassing, but they also, we want to try to stop the later disfigurement, which can be really disabling for patients emotionally and physically. And to treat the acne promptly, it will actually definitely has been shown to reduce that risk of scarring. Once the patient, unfortunately, and some of those patients do get scars, including the hyperpigmented scars in olive and darker skin, we do have several treatments that can improve scars. And that's the word I often will use for patients. The aim is to improve scars, frequently not to clear them. And that's why we need to try and prevent them in the first place. But certainly disfiguring scars with mild to moderate acne in various skin phototypes are very important and can be very distressing for the patients. And we do have, and I think this will be certainly a topic for an extended second webinar, would be what different treatments do we have for scars? And we have numerous, and we have to approach them individually as individual patients, individual types of scars, and then we can select from injectables, from topical prescription treatments, to various clinic-directed treatments, including lasers, radiofrequency, and injectables. So there's a variety of treatments that we do now have available for different types of scars, which are important to encourage the patients in. Finally, I think one of the things that we've found is that patients need a lot of guidance. They need a lot of hand-holding. They need a lot of education to keep them maintained on a treatment program. And so my daughter and I, who works with me, Dr. Philippa, we published this book a couple of years ago, which actually goes through all the aspects that hopefully are helpful for the patient, including why they're getting acne and addressing their lifestyles, their diet, etc., as well as going into the treatment options that are available. So I think that's given a relatively concise run through of where we are with acne. I think there's a lot of interesting new developments that are coming along. We haven't quite got them there as yet, certainly in this country, but there are some newer ones that will be available. And I think actually with the existing treatments, there's a lot we can do to improve and hopefully clear acne and prevent later disfiguring scars. Thanks, Vicky.